All right. Welcome back. So we have chapter 2, fluid electrolyte and acid base imbalances. So this can be a tough subject for a lot of students, but we're going to do our best with it. Okay. So, especially the acid base imbalances part, but hang in there with me. We're going to go through this together. So, fluid compartments. We talk about where fluid is. Fluid is really important in the body, just mainly because it's essential for our homeostasis. Again, homeostasis is our body's internal balance. And we are mostly water as human beings. 55 or 60% of our body weight is just pure water. So without adequate fluids, cells really are not able to function properly, and eventually without enough fluid, cell death would occur. So fluid is a huge component, and that's why water is kind of the elixir of life, so to speak. So fluid compartments, mainly there's two big breakdowns. There's ICF and ECF. So ICF is intracellular fluid. Um, and you look at them like compartments with membranes that kind of control the flow of water between the two compartments. And I always remember ICF is intracellular fluid because I see inside inside cell fluid, ICF. ECF is external cell fluid. So extracellular is anything outside the cell. So those have some subcategories, but mainly the big three is what's in the blood plasma, intravascular fluid. So what's in the vasculature and the blood vessels, interstitial. This is kind of in between. This was fluid moving out. That's fluid in between the cells in the blood vessels. There's always a little bit of this. And then there's cerebral spinal fluid, makes up its own kind of little category because it's very unique and it doesn't typically move around. It's made in one location, flows through a location, and stays kind of in its own little world. So those are the fluid compartments. So movement of water, again, this kind of goes back to homeostasis and our body's regulation. So homeostasis being a balance, what's the perfect balance? Well, however much water we take in should be the equal amount of water would leave our body. So we get water intake from obvious things, drinking fluids, of course, but we get a lot from food. Our cells actually produce a little bit of fluid for us on their normal processes. And then we lose some fluid as well through mostly urine, a little bit in feces, sweating, perspiration, and then actually a decent amount through exhaled air. Water vapor comes out with our CO2 and our exhalation. So the goal, though, if I were to take 2,000 milliliters of fluid in that day, from my cellular metabolism, from drinking and eating, the goal for my body, the complete homeostasis, would be to lose that exact same amount, 2,000 milliliters. So this should be equal. And then when they're not equal is when we get we get disease processes or conditions that develop when this is not equal. So again, this is just a chart that's in your book. It's breaking down the sources of water. So again, if this chart is saying, hey, 2,500 milliliters in, 2,500 out. Most of that's going to be liquids we drink and from the foods we eat. Fruits and other vegetables, or especially fruits, are high amounts of water, just like us. Cellular metabolism makes some, and then urine, feces, things we don't notice, like our lungs and skin, we lose a decent amount. So a balance of water and the electrolytes. We have several regulators of fluid and electrolyte balance. These are some of the highlights. Most of them are hormonal in nature, but thirst is one for sure. We have water receptors, osmoreceptors in our hypothalamus, that's in our brain. If you remember from initial A&P, hypothalamus is is a nervous system brain organ, but it's very much in control of our endocrine system and our hormone balances and a lot of other things, temperature regulation, those sort of things. So hypothalamus is a big one because it's also a regulator of thirst, which means, if we're thirsty, this is our body saying, hey, you need to drink some water because we need to keep this water balance going. Some of the big hormones involved: ADH, antidiuretic hormone. The goal of ADH is for the Kidney tubules of the nephrons in the kidneys to reabsorb water, not let water go into urine. Um, do you remember who makes ADH? Give you a second to think about it. All right. If you couldn't remember, that's all right. ADH is actually made by the hypothalamus and released by the posterior pituitary. The pituitary gland has an anterior and posterior. The posterior pituitary holds on to ADH made by the hypothalamus and releases it when we need it. Aldosterone is all about reabsorbing sodium, salt in our kidneys, and then water will follow. Um, One thing we'll talk about this chapter was sodium, and I always mention this. This was something that stuck with me with an A&P teacher I had years ago. Was talked about. Always think of like sodium as a main solute we find in bloodstream, that sort of stuff. Sodium sucks. Salt sucks. So wherever sodium goes, water will typically follow. So the hormone aldosterone's job is to retain sodium, and then water follows. Same kind of goal as ADH, but different mechanism. Does anyone remember who makes aldosterone or where it's created? Secreted by, I should say. Okay. If you answer the adrenal glands, the as I like to jokingly call them, the top hat of the kidneys, the glands that sit right on top of each kidney, those are the adrenal glands, and they make aldosterone. On that same note, there's a system involved through our kidneys sending messages in the form of enzymes to our um, kidneys. That's called the RAAS, or renin angiotensin aldosterone system. Renin is an enzyme release when there's drops in blood pressure in our kidneys. Does a big uh, enzyme cascade, you would call it, changes and converts to something that targets the adrenal glands to release aldosterone, therefore increasing sodium retention, increasing water. And if we put more water in our blood vessel, guess what we're going to get? We're going to get a raise in blood pressure. So that's how RAS controls blood pressure, but it also, its goal is to release aldosterone. And then another hormone that's involved in this balance is called ANP, atrial natriuretic peptide. And there's some other natriuretic peptides involved, but ANP is the main one. Its goal is actually to kind of regulate fluid and electrolyte levels in some sense, and it's made by the actual myocardial cells in the atria of the heart. And typically it's trying to lower blood pressure. It's okay with letting go of some water to balance our fluid out. So again, there's your homeostasis, your balancing mechanism, so to speak. It's okay with letting water go or dropping blood pressure, or losing a few electrolytes if we have too many. So let's talk about the movement of water. This is very A&P focused, and there's some words here that are important to know. Let me just explain too. You have to think of us as humans, right? We're mostly water, but we also have a bunch of particles in us, mostly these electrolytes or proteins, other hard particles that are smaller than cells. And those would be what you would call those particles, or electrolytes, proteins. You would call those solutes. And we as a human being are a solution, not a problem, right? Get it? A solution is just the liquid. So we're a solution can with a concentration of solutes in us. And depending on the concentration, the comparison, right, of solutes to um, the solution amount, that's going to tell you concentration. So just to kind of give a deeper explanation of that, if just trying to refresh from A&P, you have to kind of think of us as a solution. So we draw a couple really, well, these are supposed to be the same size, but you get the gist. So if there's two containers, each of them have some water in them. This kind of represents us. The hard particles in here, what you would call solute, is what I'm drawing here, the circles. So again, imagine these are the same amount of water, same size beaker, but this one only has like four particles in it, four solutes in its solution. Again, solution is just a liquid part of this. This container has, I don't know how many that is, whatever, we'll say 12. 12 solutes in comparison. So which one is a higher concentration of solutes? This guy right here. So this one's more concentrated. There's more particles or solutes compared to the same amount of water. So that's kind of the difference. That's what concentration means. That's what we're talking about with solutes and solutions. So fluid circulates through our body through a couple mechanisms. Diffusion is basically saying if I have a solution like that, say it's pure water here, and I take something like a concentrated dye tablet. This tablet is full of compressed dye particles, dye solutes. And if I put this in the solution, what's that going to do? That dye tablet's going to dissolve and the particles will break off and go to the edges of the container and eventually turn that water the color of whatever the dye tablet is, right? That is diffusion. Diffusion is the movement of solutes, particles, from areas of high concentration to low concentration. When you dump a solute tablet like this, a dye tablet, this is pure concentration, very little liquid in it. And I put it in a liquid, it's much more less concentrated around it. So the particles will disperse and diffuse to the edges of the container and try to equal out concentrations. That's diffusion. So filtration is based on pressure changes. Filtration happens based on pressure. So if you're kind of defining filtration, your kind of best example is kind of like a coffee filter, so to speak. How do coffee filters work? Well, we drip hot water on the coffee that seeps through the coffee because of the force of gravity and the pressure this water is exerting on the coffee grounds. And then what drips out? Fresh, nice, delicious coffee. Uh, that is the concept of filtration based on pressure, and in this case, coffee filter would be gravity. So that's diffusion. Filtration is based on hydrostatic pressure. Think gravity forcing water through coffee grounds in a coffee filter. And then osmosis. Osmosis is about movement of the water through a membrane when the solutes can't move, is basically what they're saying here. So if I scratch this, if I get rid of these, so if you kind of imagine a container with a membrane in the middle. This is a semi-permeable membrane. That's what we're talking about here, depending on the membrane. So you imagine this like a cell membrane. A cell membrane is semi-permeable, meaning it allows certain small molecules through and blocks big molecules like protein, that sort of stuff. But it'll let small stuff like oxygen, CO2, some electrolytes through. So you kind of imagine we'll use the protein molecule is too big to go through this semi-permeable membrane. Well, if I put some water in here, and I put the same amount of water in here, but this side is less concentrated, and this side is much more concentrated with these solutes, right? And water is allowed to move through this membrane. The natural process of our body and the world is osmosis. Osmosis says that water molecules are going to shift across a membrane they're allowed to pass. The solutes are too big, they can't. The water will shift and it will try to equalize concentrations. That's the goal of osmosis. So if we allow that to happen over time, what's going to happen? Oh, I didn't draw that correctly. Stand by. What's going to happen basically is that the water is going to rise on this side to try to equalize the concentration compared to the molecules. So the solutes, the molecules, the particles, whatever you want to call them, they can't move across, but the water can because it's a semi-permeable membrane like our cell membrane that's permeable to water. Okay. So what's going to happen is that water will move across, and now this side of the container is going to have more water, but it's the same concentration compared to the solutes in it. That's osmosis, and that's a natural process that happens. all the time. We can't control it. We can't really stop it necessarily. So some factors that are controlling or mitigating the flow between compartments. And so these are the concepts down here of hydrostatic pressure, which is kind of the description of what happens in filtration, and what's called osmotic pressure. So hydrostatic pressure is basically the pressure that's being exerted against the blood vessels. Okay. So when you're talking about the blood vessels, especially arteries, right, their pressure is going to be higher, and whatever pressure they're exerting against the blood vessel, that's hydrostatic pressure. And when the pressure is high enough, it's going to push stuff that can go through this membrane out. So that's fluid, that's electrolytes, that's oxygen, whatever it is. It's going to push some of these small molecules, solutes out that can go through the membrane. That's hydrostatic pressure. Osmotic pressure, let me do a different color to kind of have it do blue. Osmotic pressure is basically related to the proteins and electrolytes in the solutes in the solution. So on the other end, what controls the balance, why everything doesn't just rush out of our bloodstream, is that we have solutes like plasma proteins. One of the most common ones is called albumin. Albumin is one of the most common plasma proteins, but proteins are just like sodium. Proteins tend to suck water. So proteins suck. So this is kind of keeping this level, these hydrostatic pressure and osmotic pressure are always just in fight with each other, keeping the balance. And so hydrostatic pressure is the force or the push force that's going to push fluid and solutes out of a blood vessel. But osmotic pressure is the pressure exerted by the proteins that want to suck water and the solutes in the blood that want to suck water back in. And so when pressure changes, like for example, we'll look at in a second, in a capillary, when it dives into a capillary, the pressure drops a lot. So your hydrostatic pressure drops and loses out a little bit uh, to osmotic pressure. And so that's kind of what happens with capillaries. On the arterial side of capillary, pressure is super high. It overwhelms osmotic pressure, the hydrostatic pressure does in the capillary, and pushes the stuff out. And then that pressure starts to drop as it makes its way through the capillary. And once we get towards the venous side, the pressure is real low. So hydrostatic pressure now is real low, and the osmotic pressure wins and pulls fluid back into the blood vessel and pulls some of the other stuff back into the blood vessel based on the solute concentration again and the principle of osmosis. But if you want to think about the movement of water in and out of blood vessels, it's this balance act between hydrostatic pressure, the push force on the blood vessel, and the relationship with the osmotic pressure, the solutes and the plasma proteins that like to suck water and fluid back in. Hopefully that kind of explains it somewhat. I know that's a tough concept, so we'll talk about it more for sure. Okay, so moving on, let me erase these. Okay. So some examples that are highlighted in your book: movements of water between compartments. So again, it's noting, hey, filtration is just the concept of stuff, movement of water and solutes from blood, high pressure, to interstitial fluid, low pressure areas through a semi-permeable membrane. So at that point, hydrostatic pressure is way higher in the blood vessel on the arterial side than it is on the interstitial fluid side. Very low hydrostatic pressure. But as we get to the other end of the capillary and the pressure drops dramatically, and the venules, the smallest stuff there, venules are going to have low hydrostatic pressure. And now the osmotic pressure shifts and kind of wins the battle and pulls the movement of stuff back from ICF, from interstitial fluid, into uh, back into the bloodstream. And that's kind of the movement, the ebb and flow, the balance of this. So I were to ask you, let's go back to where we just started at. What's the primary fluid compartment inside the cells called? So this is an easy question. Just take a second. Okay. Hopefully you answer number 4, intracellular compartment, intracellular fluid, ICF. That's inside the cell. ECF is extracellular fluid. And then interstitial is part of a subcategory, basically, of extracellular fluid. And so is intravascular fluid, a subcategory of extracellular fluid. So we're talking about some fluid, some pathogens, some disease processes with this, right? So if I have too much fluid excess, too much fluid, a lot of times this leads to the most common sign you're going to see is you're going to see edema. And what edema is just an excessive amount of fluid in the interstitial compartment, basically. So extra or too much fluid in the compartment in between cells outside the blood vessel. And this is going to look like localized swelling or just a general enlargement of tissues. It could be people can have general edema in multiple places throughout the body. You can notice this sometimes depending on like when you went to bed or when you wake up. Sometimes laying in bed in a certain location dependent can cause some dependent edema, some movement of fluid based on gravity and that sort of stuff. Um, and this could mess up tissue function though, because the pressure and the pushing on other cells and tissues, and it actually can't even trap certain medications if they get pushed out of the bloodstream into interstitial fluid. That's not where they're supposed to be. The medications are supposed to be in a bloodstream to get to their target area, and maybe they never get there because they get pushed out. So edema can cause a lot of weird issues there. So what causes fluid excess? General fluid volume overload. Usually that's referred to as FVO, fluid volume overload. That can depend on people's conditions. If they have depending on their conditions, depending on if they have heart failure or some other condition that makes their venous and their cardiovascular circulation diminished, uh, loss of some of our proteins from our blood, because then that messes with that osmotic pressure. And the reason we could lose some proteins could be liver disease. Our liver is a big factor in creating and manufacturing proteins, especially the albumin, the plasma protein that we rely on so heavily. Kidney disease could let us lose some proteins in our kidneys because of damage to the nephrons, and then we're losing proteins from our blood. And then burns actually can mess with skin and the way that we maintain our fluid balance. Our skin does a pretty decent job of maintaining fluid balance with perspiration and other stuff. And that can cause fluid volume shifting and weird things. And then actually, finally, obstruction of lymphatic circulation. Our lymphatic system, if you remember a little bit from A&P, is separate from our vascular system. Our lymphatic system takes in somewhere in the neighborhood of like 15% of all the fluid that passes through our bloodstream and returns it to our bloodstream, but it goes through our lymphatic system and hopes to be screened by white blood cells and that sort of stuff. And so that is lymphatic blockages because of other injuries could cause generalized local edema that could cause cell injury or pressure on cells, that sort of thing. So overall, what's the effects? Swelling in that local area. It could be really pale. It could be red in color. It could be pitting edema. Uh, and I'll show you what pitting edema looks like, but that's basically presence of super large amounts of excess in the interstitial tissue. Pitting edema means that when I push on someone, it may leave indentions. It basically, I push a depression on your foot or your leg or your arm, and the depression stays there for a number of seconds or even longer. That's pitting edema. And then we grade pitting edema on a scale, usually like 1+, 2+, 3+. Some scales are 4+ pitting edema. It's just like, how long does it stay? If I push and I see it pit, it depresses down under my finger, but then it snaps back. That may be a 1+, and then it gets worse. And then overall, people are going to have increased body weight too, because fluid does weigh a large amount. Remember, we're 60% fluid. So that would be a factor. And this is what pitting edema, this would be severe pitting edema. I don't know how quickly this picture was snapped, but if that depression stays for several seconds, you probably call that 4+, and you can see the kind of rounding of their feet. Most people's feet, right, don't have this big rounding. Like there's no ankle. Bless this person's heart, they've got cankles bad because of not just this is not fat tissue. This is just straight up fluid shifting. So just as I'm making sure you're listening, this is just like, yes, should know this one. Which condition is characterized by excessive fluid in the interstitial compartment? Which condition is characterized by the excessive fluid in the interstitial compartment? Okay, you know this one. Number 3, edema. Edema is excess fluid in the interstitial compartment. Have that kind of definition ringing in your head, right? So on the other end of the spectrum, talking about fluid overload and edema, fluid volume excess. What about fluid volume deficiency or not enough fluid volume? Typically, this is, again, the fluid volume overload typically is going to lead to edema or swelling. Fluid volume deficiency or not enough is typically going to lead to some form of dehydration. So what's happening here? Basically, the body's inefficient in fluid. Why? Well, could be inadequate intake, too much loss, or both, really. Because again, homeostasis and the balance, if we are losing way more than we take in, that could be insufficient. So, and fluid loss, again, a lot of stuff with fluid balance, weights can be what changes it. And you may have noticed this too. Even if you ate a lot, or like if you had a time where you didn't have as much water, that sort of stuff, as much to drink, you can notice fluid volume really shifts, especially after working out and doing a lot of sweating. You can almost lose a bunch of, people call it water weight, and it's there. Um, Dehydration, just as a note, is always going to be more serious in infants, like newborn time period, especially, and older adults. Always going to be more serious in infants and older adults, just because of infants' inability to kind of self-regulate and their body learning what thirst is and that sort of stuff. And then older adults too, diminish sensations, diminished desire to drink and eat, maybe even cognitive decline, those kind of things. And then if I'm losing water, if I have an excessive loss of water, I may be also losing electrolytes, protein, that sort of stuff, other nutrients. So basically, for example, would be diarrhea. It is really bad watery diarrhea, especially a condition you probably heard of before. C. diff, Clostridium difficile, is a bacterium that can cause a super infection in the colon, causes severe debilitating diarrhea. It's mostly liquid. That's going to be a lot of liquid. We're not supposed to be losing in stool. And then we have, we absorb nutrients and a lot of stuff from our GI tract. So we're not maintaining that. We're going to lose electrolytes, proteins, nutrients. So what's causing it? Kind of talked about this already, but vomiting is one, diarrhea. So if it's going out both ends, that could lead to severe dehydration. Excessive sweating, there's going to be a loss of sodium and water. And again, kind of where sodium goes, water follows. So diabetic ketoacidosis. So if you don't remember what DKA is, diabetic ketoacidosis, is shorthand is DKA. DKA is an acidotic state. We're going to talk about acidosis and stuff, but it's related to diabetes. If blood sugars remains too high, for an extreme amount of time, it can lead to the buildup of hydrogen ions in the blood, and this causes an acidosis state. But one of the big repercussions of extreme high levels of blood sugar is that the body tries to compensate, tries to get rid of it. The best way it can do that is dump glucose out into urine, and glucose is one of those things we'll talk about in upcoming chapters. But glucose and some other things like proteins are not things you want to find in urine. Urine should be mostly waste products. So if I'm losing a bunch of glucose, it's a possibility to lose a lot of fluid and electrolytes also. Excuse me. And that will cause overall dehydration because water is going to follow that. And then for the older population, especially, insufficient water intake, or people that are on ventilators or completely unconscious or something like that, that could be super inefficient with their water intake. And then use of concentrated formula in infants, it depends on the nutrition needs of the infant, but you always have to work with the doctor and that sort of stuff when doing formula and just making sure it's the right calorie intake and you're mixing it correctly and that sort of stuff. But your big cause of dehydration is probably somewhere in the neighborhood of excess sweating and loss, for instance, like heat stroke, and then vomiting and diarrhea. Just think coming out both ends, I'm losing a lot of electrolytes, a lot of stuff. So, what does effects look like? What does it look like to be dehydrated? So, someone's going to have dry and really rough membranes in their mouth. Those are known as mucous membranes. So, really, really dry, um, chapped lips, dry around the mouth. Like they're not going to be pink and moist. Decreased skin turgor or elasticity. So, just kind of if you didn't hear about skin turgor with AMP, what is skin turgor? Skin turgor is basically where say if you were to right now, and you could do this at home, right? Just take the back of your hand and pinch it up a little bit. Don't hurt yourself. That should snap back. It should be elastic. My skin should just snap back into place. If I were to do that and my skin kind of stayed up a little bit, it kind of tinted up. That would be a kind of a earlier mild sign of dehydration. Um, because the cells have kind of shriveled a little bit. They're not as elastic and not the same form they should be. And that's a nursing assessment technique actually to verify or kind of keep up an eye on dehydration. Um, they'll have a lower blood pressure because there's probably loss of fluid from the vasculature, kind of a weak pulse and general fatigue and tiredness. They'll have a weak pulse, but it's likely their body will try and compensate with having a higher heart rate. So we say weak pulse. When you say weak pulse, you're talking about when you feel it, you palpate it, it doesn't feel as strong. It could still be fast, and it's likely to be faster because there's not enough fluid. So the body is working, trying to keep fluid in the vasculature flowing at an effective cardiac output rate. And that means the heart rate will go up. People also will have an increased hematocrit. So hematocrit is the percentage of red blood cells in a blood sample, and it's going to go up because that's what a percent that's just representing a concentration of red blood cells. So if I have less fluid in my bloodstream, then it is more concentrated, and so that percentage will slowly climb. And there's also on the very severe dehydration and just overall confusion, decrease mental function. So again, what does our body do what does our body do to mitigate this fluid loss? The hypothalamus is going to kind of increase that thirst response, say go get some water. The heart rate's going to increase, like I said, to try and compensate for cardiac output and keep it consistent. Blood vessels are going to constrict, especially at the skin and far extremity level, as an attempt to kind of redirect blood flow to like organs and the central trunk of our body. And then overall urine output is going to drop. And when we do make urine, that's going to be very highly concentrated. So we talked about dehydration. What's a common effect of dehydration on the skin? All right. So basically, yeah, decrease skin turgor and elasticity. Again, turgor kind of just basically means skin elasticity. So that's going to decrease, and we're going to see tinting in a dehydrated patient. So, third, spacing of fluid. This means that fluid, again, is shifting out of the blood into body cavity or tissue and can no longer re enter vascular compartment. Third spacing usually is talking about not necessarily just edema, but talking about fluid moving into other fluid compartments. So a little bit from A&P, a lot of our lungs, our heart, and all of our entire abdomen have these membranes, these serous membranes around them that kind of help with movement and protection. But those serous membranes are usually double layered, pericardium around the heart, pleura around the lungs, for example, peritoneum around the abdomen. They're all double layered membranes that have serous fluid in the middle. Well, third spacing is saying instead of edema, that fluid is now shifted into those places and causes large amounts of swelling. So that could be around the lung. That's called basically pleuritis or pleurisy, kind of an inflammation, fluid buildup in the lungs. Ascites would be fluid buildup in the peritoneum. Uh, Pericarditis and other fluid, that's not good because now that's affecting some of our most vital organs directly. And this could be a cause of fluid volume excess or people with conditions like heart failure that have trouble regulating their blood vasculature. So, talking about electrolytes now. First one to talk about is sodium. Sodium, as kind of a review and a reference, is the most abundant ECF electrolyte we have, extracellular fluid. It's the most abundant we find in our bloodstream and outside the cells. Very important for regulation of many things. I'll let you kind of think about why it's important, but overall, sodium is hugely important for muscle contraction, nervous system impulses, and sodium and potassium that we'll talk about in a second have somewhat of an inverse relationship. Sodium usually we want to find outside the cell, potassium we want to find in the cell. And we have all these sodium potassium pumps, these active transport pumps, and pretty much every cell. That's goal all the time is to keep pumping sodium out and keep levels at a certain level outside and keep pumping potassium in the cell. Keep levels okay there. Normal range for sodium is highlighted in your book. It's 135 to 145, and all these are in milliequivalents, which is not a metric system measurement. It's a smaller measurement that's used predominantly with electrolytes. 135 to 145 milliequivalents per liter is a normal lab range for sodium. Again, my focus is more of the understanding of the concepts, not that you have to exactly know the range of sodium all the time, but I think it's good to start learning this now because this will get hammered home in adult health 1 and 2 and 3. It's going to be a big part of adult health is knowing these labs. So I'm just throwing it out there now as a super, super hardcore, nice to know, but not necessarily need to know for your exam. So sodium imbalances, hyponatremia. So talked a little bit about medical terminology already in this class, but overall, some of you hopefully have heard before hypo and hyper. Hyper, HYPER, hyper is like too much, high, hyper, high. They sound very similar. Hyper is high levels of something, too much of something. Like think of a hyperactive kid. Hypo, HYPO, is low and slow. I always have to say it like the hypo, low and slow. So excuse me, stuttered. Hypo is always going to be a lower amount or slow or lacking. Okay. So hyponatremia is not enough sodium. Sodium is hyponatremia. So the chemical name for sodium is Na. So hyponatremia, or you can think natremia. Anything emia as a suffix is going to be talking about the blood. So hyponatremia, if we're doing medical terminology breakdown, basically says low amounts Na sodium in emia blood, if that makes sense. So hyponatremia is low sodium in the blood. So what's causing this? What happened? How do we get below? This would typically be, considered below the 135 mark because the range is 135 to 145. It'd be excessive sweating, definitely in those dehydration, heat stroke kind of scenarios. Vomiting, diarrhea. Again, there's a lot of electrolyte loss in vomiting and diarrhea. There are certain medications like diuretic medications that have been known to cause losses of sodium in fluid because what diuretics do, the word diurese and a diuretic medication, the goal of them is to increase the amount of urine output by a lot. And in that case, sometimes that can mean we lose excessive electrolytes when we're not trying to. And then hyponatremia is also an early sign of chronic renal failure because in early chronic kidney failure, there tends to be, again, that kind of loss, a diuresing of loss of lots of water and fluid, which sodium kind of goes with. A rare case for hyponatremia is excessive fluid intake, kind of known as water toxicity. Very rare and hard to do. It's very hard for you to drink so much water that you would cause toxicity to your body and hyponatremia. We love water. We need water. So very rare that you can drink too much water and give yourself hyponatremia. What are the effects overall? To kind of summarize the effects, stupor or like general confusion, malaise. Stupor would be more like disorientation and drowsiness, can cause seizures. Sodium balance has a lot to do with muscle and nervous system impulses. So, sodium out of balance, you think seizures or odd things with our nervous system. And then you think muscle weakness, and then actually can cause some nausea and vomiting. More think of the stupor, seizures, neurological nervous system changes, and muscle weakness. So, hypernatremia, again, high sodium in blood, emia. So usually this is a case of weird imbalances between sodium and water intake. If someone's ingestion of large amounts of sodium, I think that's probably more rare, but potential if you're, I don't know, hot dog eating contests, maybe. I don't know what, you have a high salt content in your diet. I suppose, yeah, hypernatremia is very possible. Typically, this comes from uh, cause usually more of a watery diarrhea instead of just general diarrhea. But like the C. diff example I gave, watery diarrhea, like pure just liquid diarrhea means the liquid is getting out and the sodium is staying there. So we're losing liquid um, out of uh, our body, and the sodium's not going with it, or it's staying in enough concentration that basically that concentration equation has now changed, where we've lost so much fluid from our blood vessels that sodium is now a higher concentration in the blood. This could be from dehydration too, necessarily, if someone was super dehydrated, that they lost a lot of fluid shifts from their blood vessels, then they could have high sodium levels. What effects is this going to have? Think kind of the opposite of having too low of a sodium, but they're going to have kind of very similar signs to dehydration, probably dry and rough mucous membranes. Urine output could be sluggish as the body tries to compensate and keep fluid in there to kind of dilute the sodium level in our blood. And they're going to have general like muscle weakness and generalized weakness. And instead of like more of a neurological, I'm in a stupor, I'm kind of blah, I'm confused, I'm kind of out of it, sleepy. Think of this like they're gonna have weakness and but agitation. They're gonna have like an aggressive, more heightened sense of their neurological, like their nervous system is gonna be firing weird, and they're gonna be their brain is gonna be very like agitated and combative even. So, which hormone is responsible for reabsorption of sodium and water in the kidneys? So, this goes back to kind of, I talked about some of the regulators of electrolyte and water balance. So, what's specifically targeting sodium reabsorption in the kidneys, and then water follows? Give you a second to answer that. It's correct. It is aldosterone. Aldosterone. ADH does help us reabsorb water, but it doesn't do anything with sodium. ADH is trying to just reabsorb the water. Nothing to do with sodium. Okay, so moving on to the next electrolyte, we have potassium. So potassium, kind of review normal potassium blood levels for most places. Again, normal levels for electrolytes can vary slightly depending on textbook and that sort of stuff, or what facility you work at. Sodium seems to be pretty consistent, but sometimes potassium can change a couple decimal points. But overall, most people consistently say 3.5 to 5 milliequivalents per liter. And this is the most abundant electrolyte we find in ICF, in intracellular fluid. And you can see that kind of comparison because The normal blood test range for sodium is like 135 to 145. Potassium is much lower. Why? Because we don't really want to find it in our blood. It's supposed to be an intracellular electrolyte. So 3.5 to 5. The big take home point for potassium imbalance that you have to keep in mind is potassium is super important for cardiac muscle conduction and contraction and relaxation. So a lot to do with our electrical impulses that run through our heart that produce our heartbeat and produce the contractions of the heart, and very important for specifically cardiac muscle. Most of your potassium you will find in muscles um, and muscle cells, but especially of the cardiac muscle. So super important for cardiac conduction, cardiac muscle contraction. If there is an imbalance, either way with potassium, low or high, you think ECG changes. ECG, if you don't know, is electrocardiogram. ECG is what we use to measure someone's rhythm in their heart. Does that QRS complex? That is the problem. Arrhythmias, dysrhythmias, weird things with their heart rhythm. That is potassium imbalance in a nutshell. You've got to think high or low, doesn't matter. Just think weird cardiac issues, high alert, ding, ding, ding. I'm worried about potassium. Okay. So, what's causing potassium levels to shift? So, causes of the hypokalemia. And again, just breaking down the word, hypo is low or slow. The kalemia, the K is basically the scientific like periodic table for potassium is K, just like sodium is Na, potassium is just K, and emia is in blood. So cal being potassium, emia blood. So low potassium in the blood. Definition is usually generally below 3.5 is considered hypokalemic. What's causing this? So it could be excessive losses in diarrhea. Again, diarrhea can play a huge role in balancing this stuff out one way or the other. Some diuretic medications. There's some diuretics that don't. There's a couple different categories of diuretic medications, but their goal is all the same, to get rid of it, large amounts of fluid. Some will try to not let potassium go. Some don't try to, and potassium can go out with those diuretics in the urine. Excessive aldosterone and other glucocorticoids. These are the hormonal steroids produced by our adrenal gland. One is Cushing's syndrome. If you don't remember Cushing's syndrome, it's excessive excretion in the adrenal glands, excessive cortisol levels. This, along with the excessive aldosterone, all this. What does aldosterone do? Well, Cushing's is basically this hypersecretion of all the adrenal glands. And so it's going to affect the immune system, but it's also going to affect sodium retention. So someone with Cushing's is going to have excessive sodium retention and fluid shifts, but that means they're going to get rid of potassium. So potassium and sodium, because those potassium sodium pumps that we have through all our cells, typically they have an inverse relationship, right? So if we're losing sodium, potassium might go on the rise. If we're losing potassiums, that sort of stuff, the balance is out of whack. So if we are retaining a lot of sodium, that means that potassium is getting pushed out. Another common thing is alcoholism, general eating disorders like bulimia, that would be involved vomiting, anorexia, that would involve just starving themselves, and that would lose a lot of nutrients and a lot of intake for potassium. Again, another one that messes with potassium levels is diabetic ketoacidosis, DKA, high levels of blood sugar causing an acidotic state. We'll talk about acidosis more, but acidosis tends to mess with electrolyte levels, because especially the electrolytes in the cell, because acidosis is all about hydrogen ions, which we'll talk about. But what hydrogen ions do is they'll get so high that they'll start shoving their way into cells, and that pushes some electrolytes out of the cell, and then now the potassium gets wasted. So it's not always a good sign there. So what is the effects of hypokalemia? Again, biggest thing, cardiac dysrhythmias, cardiac arrhythmias. There's going to be some muscle weakness, flaccid muscles, that sort of thing, general fatigue. Probably paresthesia. Paresthesia is if you've ever sat on your hand or laid on your hand, right, and you woke up and it was numb and tingling, that's paresthesia. It's like a numbness, tingling sensation in fingers and feet. That's paresthesia. So yeah, paresthesia, cardiac dysrhythmias. The cardiac stuff is always going to be your biggest concern with potassium stuff. So hyperkalemia on the other side, uh, definition is an elevated potassium above 5. Causes, the first one listed here is the biggest culprit. Yeah, the biggest culprit is renal failure. So when the kidneys don't function properly and nephrons start to destroy and urine's not really being formed, then potassium is not getting balanced by the kidneys. Our kidneys are a huge important guy in balancing fluid and electrolytes. If you want to think of one organ that was about this balance of fluid and electrolytes, it's going to be our kidneys. So they tend to, if they're failing, someone's in chronic renal failure, whatever it is, they tend to have a harder time processing and controlling potassium levels, and they kind of tend to rise. Diuretics again, but this time a different category of diuretics called potassium sparing. Those diuretics, our goal is to, not lose potassium out of the kidneys when they're diuresing somebody, but in that they could potentially lead to potassium levels building up. And then something like burns. Burns is always going to mess with electrolyte issues because of our tissue's ability to regulate its fluid and electrolyte balance. So extensive tissue damage, extensive burns could cause hyperkalemia as potassium is leaking out of dead cells into the bloodstream. Um, that sort of stuff. Then acidosis again can cause this. And like I talked about, hydrogen ions tend to shove their way into the cell and take over, and some stuff gets pushed out, like potassium. So affects what's going to happen to someone with hyperkalemia. Again, cardiac dysrhythmias, cardiac arrhythmias, just abnormal rhythm to the heart, abnormal heart contraction. It could even lead to cardiac arrest. And again, the effects of low and high potassium are very similar. With the high potassium, it tends to be a larger risk um, that they're going to have cardiac arrest or some kind of severe cardiac event. But either way, high or low, you're worried. Similar signs and symptoms for both high and low, basically. Muscle weakness, um, to the point of respiratory issues, and then paresthesis again, that sort of stuff. So, what is a potential effect of hyperkalemia? If you answer number two, you're correct. That's the most important thing you got to take away. That's the need to know from potassium. High or low, you're thinking cardiac issues, and high is a little bit more risk of severe cardiac arrhythmias. So, some other electrolytes to highlight: calcium. Where is calcium found? Mostly our bones. Our bones are majority calcium and a little bit of phosphorus. Um, Calcium is important. We get calcium, from milk. We get calcium based on our exposure to sunlight, actually. Vitamin D that's absorbed by our skin. This gets processed in our kidneys, and this helps promote the movement of calcium kind of out of bones and into the bloodstream for us to utilize calcium. Calcium is super important for muscle contraction. Here's a theme here: muscle contraction, nervous system impulses, and then you can actually add blood clotting to this list. So far, kind of everything has this wheelhouse of what's it important for. Calcium, hugely important for skeletal muscle contraction, mostly, but all muscle contraction and definitely blood clotting and nervous system impulses. And we need the vitamin D from the sunlight to kind of help promote the movement of calcium around the body. Uh, and who controls this? If you kind of refresh on the endocrine system, we have our parathyroid gland that releases parathyroid hormone that helps raise potassium levels. And then we have a hormone released by our thyroid gland called calcitonin that helps to decrease calcium levels. So again, this is just a summary. What's the function? It's the structural component of bones and teeth, nerve membranes, muscle contractions, so nervous system impulse, muscle contractions, lot of metabolic processes, and we need it to help with blood clotting. So the big three is nervous system, muscle contractions, blood clotting. And then, well, I'd say the big four is obviously it's the foundation of our bones. So what's causing some of these imbalances? So cause of hypocalcemia. Um, there's a couple things. Hypoparathyroidism would be not enough or an underactive parathyroid, which means underactive PTH. So underactive parathyroid is saying there's not enough of that PTH hormone. Therefore, the goal of PTH is to kind of raise blood calcium levels. So it's not doing its job. So blood calcium levels decline. Malabsorption syndrome is basically talking about there's a decreased vitamin D absorption, and then therefore the processing of calcium ions is not correctly distributed from the bones to the blood. That's more common in people that are lacking sunlight and UV exposure to get enough vitamin D. Um, Deficient serum proteins based on how they interact. Um, and then probably the biggest one for is probably the hypoparathyroidism, malabsorption syndrome, and then renal failure. Again, malabsorption and renal failure go hand in hand with calcium levels, keeping them higher, along with the PTH, is because vitamin D is activated in the kidneys. And if there's kidney functions not very well, limited vitamin D activation, and that tends to mess with the calcium conversion into the bloodstream. And also that means we probably our kidneys are retaining things like phosphate. Phosphorus is another electrolyte that tends to have an inverse relationship, meaning kind of they're balancing each other out with calcium. So if our kidneys retain a lot of phosphorus or phosphate, excuse me, the singular term, then it's potential that we're going to have a losing battle and have low levels of calcium. What happens? Very similar to some of our other stuff, but you think of when I have low calcium, let me explain it this way because this one confuses people a lot. So when you have low calcium, you tend to have a more excitable immune system. So spontaneous muscle contraction, twitching, a syndrome called tetany. Okay. So basically, how it works, if you kind of imagine muscle cells, they like calcium on the inside. When I have low calcium in the bloodstream, what this is saying, remember our principles of kind of diffusion and concentration here. If the blood level of calcium is low, right, you have to look at this like a balance. This balance is out of whack. It's supposed to be here, but now it's like the cells are winning with excessive amounts of calcium and not enough in the bloodstream. And so I look at it like that, where now the calcium in the cell is more excitable, or there's some kind of shift from the bloodstream to the cell. So this increases excitability of the muscles. So when someone has hypocalcemia, not enough in their bloodstream, it's like, again, this is not exactly how it works, but I think this is the best way to explain it. You just think of it like if I got low calcium in my blood, that's insinuating that the calcium is more active and higher in the cells, and therefore muscle spasms go bam, 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 spasms, twitching, thing called tetany. Tetany is this condition where wrist muscles lock and hand muscles tighten up in like almost like a locked position. That's tetany. It's going to mess with the heart conduction as well as a muscle. The heart's a giant muscle, and could cause some dysrhythmias, that sort of stuff. So what could cause hypercalcemia on the other end. So let's talk about, so that's hypocalcemia. So hypo, again, not enough calcium in the bloodstream. You think more excited muscles, more excited nervous system impulses, twitching, muscle spasms, arrhythmias, tetany. Hypercalcemia, what could cause that? Well, hypo could lead from impaired kidney function, right? Malabsorption syndrome. What's causing too much calcium? One predominant cause could be bone neoplasms, so bone cancer. Can affect the regulation of calcium and phosphate levels in the bone, and there could just be a bone tumor that's has just unregular, because remember, cancerous neoplasm cells don't really respond to the body normally. They kind of do their own thing. They're not under direction of the rest of our body. They're their own little guy out there doing whatever the heck they want. And so bone cancer and bone neoplasms are going to cause uncontrolled release of calcium from the bones. And that's going to dump it into the bloodstream. Instead of hypoparathyroidism, hyperparathyroidism, hypercalcemia, hyperparathyroidism, too much parathyroid hormone. The goal of parathyroid hormone is to keep calcium levels high in the blood, but if I have too much of it, it's winning the battle. Again, homeostasis is messed up. Now I'm out of order here. And then actually immobility, not being moving around that much from whatever it was, some kind of hospitalization, uh, um, paraplegia, loss of function in legs or quadriplegia, leads to bones being destroyed faster than they're being rebuilt. Bones need to, just like muscle, they kind of, if you don't use them, you lose them. And so muscles and bone need to have weight bearing exercise and be stressed so they can undergo rebuilding. If they're not being stressed, then they tend to just keep kind of breaking down over time. One rare thing is, those are the need to know. The rare would nice to know would be like increase milk or other consumptions in that family, or increase antacid consumption, actually, specifically Tums and some of the ones in those families. Those are designed to decrease acidity, but they're calcium bicarb. They are full of calcium. And so they can actually increase calcium levels in the bloodstream by abuse. It's rare. I've only seen it once in my whole career. That's rare. So what's going to happen with hypercalcemia? So think for this, too much calcium in the blood means there's not enough in the cells. Again, the opposite for hypocalcemia was like there's not enough calcium in the blood, too much in cells. So hyperactive muscles. Hypercalcemia is think everything is decreased. Neuromuscular function, so nervous system impulses, muscle, all this stuff is weak, bad flaccid muscle tone. I'm drowsy, I'm lethargic. Um, and then again, kind of the similar dysrhythmias could occur, irregular heartbeats, that sort of stuff. So these are just kind of, again, can mess with kidney function, that sort of stuff. But overall, think confusion, or think drowsiness, stupor, muscle weakness, flaccid muscles, that sort of stuff. So what's the primary function of calcium in the body? From the, if you had to pick from these answer choices, yes, we know they're mostly bone, but let's think a little more advanced, right? You answered number two. You're correct. So let's talk about magnesium imbalance. Let's talk about a couple here to finish off the electrolyte conversation. Magnesium is mostly inside the cell. So hypomagnesium usually is malabsorption or malnutrition, um, usually associated with alcoholism because of the way our body processes alcohol. And then that alcoholics, the people that suffer from alcoholism, tend to not have the most regular and nutritious diet, so hypomagnesium, could be diuretics, and some other odd things. But I think this, again, this is one slide short. I think hypomagnesium, you think it's very similar to kind of like the same as Calcium, where it's low levels in the blood, cause increased neuromuscular function, excitability, and what could cause it, usually associated with malnutrition, malabsorption syndrome, alcoholism. Too much magnesium, uh, what is going to cause? You're going to think uh, or excuse me, depressed muscles, depressed neuromuscular function. This typically is usually caused by renal failure. It's a common cause of hypomagnesemia, too little magnesium. All right. Answer number four, you're correct. All right. To finish off some of these electrolyte imbalances, phosphate, um, it's part of the tooth and bone formation. It's a small percentage of that. It is important for metabolism. It's important with buffering our acid base balances. We'll talk about this a little bit, but one of our ways that our body helps with acid base balance is the chemical phosphate. So if that's out of whack, that could throw that out of whack. And it has a reciprocal inverse relationship with serum calcium. So again, the calcium goes up, phosphate goes down, calcium goes down, phosphate goes up. So too little phosphate, back to the malabsorption syndromes. Too much too much phosphate, renal failure, very similar to magnesium for the predominant causes, and that's pretty consistent across a lot of the electrolytes. Last one to highlight, chloride. Um, it's in the outside of the cells mostly. Chloride and sodium kind of follow each other. Chloride and phosphate are important for helping us fight acid base imbalances. Um, if I don't have enough chloride, could be associated with vomiting and losing a lot of my acid from my body. Too much chloride is really just too much sodium chloride intake. Um, but that's hard to do, kind of rare. So again, these last few are more minor. The big take home points is get an idea of sodium, potassium, calcium, and magnesium. Those are kind of the big four, I would say. But definitely the big three is sodium, potassium, calcium. So to finish this long chapter two off, chapter two is acid, base, and balances. So what is acid? What is base? Let's talk about that. So acid base balance is super essential to homeostasis. It's in the word balance. It's in that naming. So cells, the enzymes in cells, they only function within this really narrow pH range. So what is pH? pH is a scale that basically just measures the amount of hydrogen ions we have. So normal pH for our body is 7.35 to 7.45. I will say that's a need to know kind of range. You're going to want to keep that in your brain for a long time. Death is going to occur if our pH fell anywhere below 6.8 or 7.8. I've never seen a 6 pH. If they were probably in a coma. I think the lowest pH I've ever seen was 7. I think 1.5 or 1.4, something like that, and they were already in a coma. So it's a really short range. But again, what it's basically saying is pH is a scale that some scientists somewhere came up with, right? But it's a scale where we sit kind of in the middle. We want our blood pH around here, right? Really acidic things. You could think of these like lemons would be like a number two, stomach acid, that would be like a number one on the scale. So the lower the scale number, the more acidic it is, the more hydrogen ions there are. Okay. The higher the scale, the higher the number, the less hydrogen ions are involved, and the more what's called basic or alkaline. Same thing as basic. So bleach would be up here at like a 14, I think, and some other components are really alkaline. But anywhere on either side of this scale is corrosive and bad for our cells and us as a human. So it doesn't really matter as much as for acid base imbalance, it's all related to how acidic something is. So a lot of the thing to note is that most of our cellular processes produce byproducts that have hydrogen ions associated with them. So most of the cellular metabolism and cell processes we do, the result is going to be hydrogen ions. It's going to be acidic. So our body tends to lean acidic. Alkalosis is a little bit more rare. It's possible, but most of the time our body tips on the scale to a more acidic state. Another thing to note about the alkaline side is that when you think acid, you have to think hydrogen ions, and that's what the scale is measuring. When you think this side, when you think basic or alkaline, you're thinking about a different type of molecule that's called bicarbonate. Bicarb starts with a B, basic starts with a B. And this is the balancing act. We get too acidic, means we have too many hydrogen ions that are winning the battle, bicarb's losing. We get alkaline, we have too many bicarb or not enough acid, that's winning the battle. So that's what we're going to kind of talk about with this. Again, this is all related to hydrogen ions. So again, our normal range somewhere between 7.35 and 7.45. That's where we want to be. So if acidosis, I'm having more hydrogen ions, and the pH on the scale number, the pH number scale, it's just a scale, that number decreases. If I have not enough hydrogen ions, I'm less acidic, I'm more alkaline, I'm more basic, the number goes up on the scale. Quick review. Were you paying attention? What is the normal serum pH? Okay. If you answer number 4, you were correct. Okay. How do we control pH? So we have some systems in our body that are called buffer systems that are trying to do that. So buffer systems, the fastest is what they call a chemical buffer system here at the top. Basically, we have some chemicals like phosphate, chloride that tend to bind with hydrogen and then basically change its molecular structure and get rid of it. This usually happens in blood. So slight variations in pH, those chemicals can grab the hydrogen ion, bind with it, and bring our pH back to normal, back up to normal. And this happens all the time while you're sitting here, a million times a day, really quick and fast and speedy. If we started to have some kind of condition that was causing elevated levels of hydrogen ions, then our respiratory system might have to kick in. So you notice this whenever you go running or whatever, you work out, you start breathing hard. The reason that's happening, not just because you're working out, but one reason is too, is that a lot of your cells doing all that hard work, your muscles produce acids as a byproduct, like lactic acid from your muscles. And your body has to do something with those hydrogen ions. So your buffer, your chemical buffer is going to do as much as it can, but it can't do that much once that level increases. And so then your body will increase your respiratory rate to try to blow off more acid. Because another thing to know about chemicals is that carbon dioxide, CO2 that we breathe out, CO2 and hydrogen ions, they are in love. They love each other very much. Okay. They love each other very much. So CO2 can combine with hydrogen to make carbonic acid, is what it's called. CHO2, COH3. I think I get my chemistry has always not been as good, but they make carbonic acid, and that breathe out. I breathe out the acid, and that's going to help regulate my pH. Lastly, our last buffer system is our kidneys. Again, buffering and controlling the level of pH in our body. Uh, the kidneys are our strongest, but they're the most powerful buffer system we have, but they're the slowest to kind of kick in. Okay, so they can directly just excrete hydrogen ions or absorb the inverse relationship. They can absorb bicarb to balance out the pH. They're the most significant and strongest control mechanism for pH we have. But again, they're the slowest. They take time, hours, days to kick in, where chemical buffers are happening all the time. Respiratory can kick in seconds or minutes. Kidneys take some time to get involved, but they're the most powerful. So, what are the four types of acid base imbalances? There's only four, which is good. And they're in kind of two subcategories. They're either going to be respiratory related or they're going to be metabolic, which means anything else. So if it's nothing to do with the lungs, it is metabolic. If it has to do with the lungs, it's got to be respiratory. And then you can either be some kind of acidosis state, that would mean above 7.45, or excuse me, below 7.35 on the scale, or you can be alkalosis, which would be above 7.45. So that's it. That's all you got is these four types. So if I'm respiratory acidosis, that means there's probably increased levels of carbon dioxide, which again, carbon dioxide and hydrogen love each other very much. This means that there's more hydrogen ions. Therefore, I'm going to be acidotic. My pH is going to drop on the scale. If it's metabolic, it just has nothing to do with the lungs, anything other reason. Typically, this means that the levels of hydrogen ions may not increase, but I'm losing bicarb. So now the balance is out of whack and hydrogen is winning the battle. And so I'm in a metabolic acidosis state. Respiratory alkalosis on the other side is meaning I'm actually losing carbon dioxide, therefore losing hydrogen. And now bicarb is winning the battle. And that puts me in alkalosis state. You think, yes, carbon dioxide is what we breathe out. It's what we make from cellular metabolism, but we want to keep an appropriate level in it. Metabolic alkalosis, not the lungs, so it's metabolic, is I'm probably losing hydrogen ions through our GI tract, through the kidneys most of the time. So let's look at this a little bit more in depth. So what is compensation? Compensation, kind of as a definition, is the body's, this is homeostasis, what we do. It's the body's ability to kind of try and correct it. And this is usually kind of a short term. Whatever our body does to compensate for an acid base imbalance, it doesn't help us, obviously, right? It doesn't help us stop the cause of the imbalance, remove the cause of the imbalance. That's got to be treated, but our body will try and compensate. So how's it try to compensate? The buffer systems is basically compensation. Chemical buffers, phosphate, chloride, change our respiratory rate, increase renal function, make more urine, that sort of stuff, get rid of hydrogen ions. That's the compensation. Decompensation, this is when the problem is more severe. Other problems step up, and then basically the compensation mechanisms start to fail. This requires intervention from outside source. This is where acidosis becomes life-threatening, when our compensating mechanisms, the buffer systems, start to fail. So again, another chart to kind of summarize it. If I'm acidosis of some kind, I've got to have too many hydrogen ions. There goes down my pH. Alkalosis means I probably don't have enough hydrogen ions, or I have too little, or I have not too little hydrogen ions, or I have too many bicarb molecules, and pH will increase. And this is the chart that's kind of in your book that talks about it, shows it. So again, acidosis for respiratory, it's going to be I'm shallow breathing, that sort of stuff. So my CO2 is increasing. therefore causing respiratory acidosis. And again, alkalosis is basically saying I have decreased CO2. This would be anxiety, panic attacks, cause fast, shallow breathing, or fast breathing that's blowing off a lot of CO2. This is actually respiratory alkalosis is something that can happen with panic attacks and hyperventilation. You would have seen like maybe in a movie or something, someone's having a panic attack, freaking out, and someone gives them a brown paper bag. Well, the reason they're giving them a brown paper bag is so that they, when they're freaking out and blowing off CO2, they actually breathe it right back in. The brown paper bag keeps it in place, and so they can maintain their levels of CO2, thus maintaining their hydrogen ion levels and maintain their pH. On the metabolic side, acidosis, the most common is probably kidneys failing and leading to not being able to get rid of enough hydrogen ions, or diabetic ketoacidosis. Bicarb tends to drop. On the other side, alkalosis could be vomiting or excessive antacid intake, because most antacids, Tums or name brand, but they're all calcium bicarbonate. They are bicarb. So I've increased the bicarb level, and the kidneys have to kind of compensate. Vomiting, I can lose a lot. A bicarb or excessive stool or diarrhea actually could lose bicarb, because bicarb is absorbed from our food and our stool. So again, respiratory, let's go through these individually. Respiratory acidosis, pneumonia, airway obstruction, something like that, causing increases in CO2, causes increase in hydrogen. And we'll talk more about these in class. This is more common with COPD, any kind of obstructive disease. Metabolic acidosis is I'm losing too many bicarbs, diarrhea, losing it from my intestines, renal failure, can't get rid of the acids. So, what does acidosis affect? Well, again, acidosis, the kidneys are going to try and compensate, lungs will try and compensate, but we're going to end up with higher acids, higher CO2, and eventually our body will not be able to compensate anymore. For alkalosis, the respiratory again is anxiety attack, breathing like that. Uh, the metabolic side is usually just an increase in bicarb. So if I were to vomit and lose stomach acid, that is an acid. If I was to have too many antacids ingest them, that could be an alkalosis state. Alkalosis is going to be uh, uh, mess with calcium levels, seizures, stupor, coma, restlessness. Overall, for treatment of imbalances, just got to keep in mind, you got to find the underlying, what's causing it. That's the big thing. And then take corrective measures. We can give bicarb to reverse acidosis. And then in the future, we can look at their health history, look at their plan, make sure that their diet and other stuff. And, if their problem with, if they get developed alkalosis from over abusing Tums, it would be education about, we can't do that. Right. So some questions to finish off. What is a common cause of metabolic acidosis? I'll give you a second to answer. So again, balance. I have all these answer choices. Excessive loss of bicarb is going to mess up the balance of acid to bicarb. What's our primary buffer system in our blood? All right. All right. So that should round everything out. Hope that was helpful. Thank you guys for listening. I'll catch you next time.